And I see Dr. Linares is just joining us now, so that's wonderful. But I'll introduce our speaker, and this is Dr. Shen's first time joining us for ECHO, so thank you for joining us for the first time and presenting. Dr. Shen is an associate professor in the Department of Speech and Hearing Sciences, and I know that hearing impairment is something that comes up in primary care, maybe not as often as it should, but we're going to learn more today about a good approach to addressing hearing loss in older adults in the primary care setting. So thank you so much, Dr. Shen, for joining us. I really appreciate it.
Thanks, Kate. Thanks for the invitation. It's my pleasure to talk to you all about age-related hearing loss. It's related to my research, but it is too big of a problem for our small field of audiology. So through this talk, I'd like to invite other professionals to come join the force so our older adult patient will feel well supported. So that's the topic. Age-related hearing loss is a highly prevalent public health issue. As a part of typical normal aging process, we typically acquire age-related hearing loss as we go up every decades of age. So in this chart, you can see the percentage of older adults have one form or any form of hearing loss. And the prevalence is higher in male versus female older adults. On the right here, this is an indication of what kind of hearing loss older adult has. So we have what we call audiograms on top. On top, we are showing the male average audiograms for different decades of age in different symbols. At the bottom here, we have female average audiograms. The x-axis going from bass on the left to the triple high frequency sound on the right. Lower in the graph means poor hearing sensitivity. As you can see, that age-related hearing loss mainly impacting high frequencies. That's mainly impacting those speech sounds that are consonants, fricatives. So a lack of clarity of these consonants are mainly what these older adults are struggling with. And of course, age-related hearing loss is not just an isolated problem. According to the ICF model by WHO, impact of hearing loss, having trouble to hear is only one aspect of its impact, meaning the impact of bodily function and structure. But we also have to appreciate that hearing loss may have other impacts, like create limitation to daily activities and create restrictions to education and employment opportunities. Untreated hearing loss is statistically associated with higher risk of social isolation, depression, dementia, falls, and inability to work, travel, and other physical activity. So on the right, this graph is showing using dementia as an example. So among all the modifiable factors, so modifiable factors are those color lines. Hearing loss count for 9%, which is the biggest, strongest predictors, risk factors for dementia later in life. So this is an important problem to address, not just because this is a hearing problem. It is have a more wide impact of someone's quality of life. In audiology, the main tool to address age-related hearing loss is through hearing aids. However, on average, from the first diagnosis of hearing loss to the final purchase of a hearing aid, there's on average of 6 to 7 years of delay. And the reasons behind this lack of adaptation is complex. Some of the factors have been identified, include lack of affordability. So a pair of premium hearing aids could cost a couple $1,000s, often out of pocket. So this is definitely not at a level that is easily affordable for many older adults. Another factor is lack of accessibility. In the survey result, you can see that majority of people identify distance as the reason why they felt they have a lack of accessibility to hearing healthcare. For many Americans live in rural area, going to see an audiologist means to drive a long way from home. So these factors has already been known in our field for a long time. However, it really captured the attention of central administration in the 2000s, and then in 2015, presidents appointed the council about this hearing healthcare issue, and they issued a report, identified lack of affordability and accessibility is one of the top priorities to address. And hence, in 2017, there's a bipartisan bill on over-the-counter hearing aids. So thinking that if we are make hearing aid available over the counter, that may help reduce the cost of these devices and accessibility. So finally, in 2022, in October, we finally had the first over-the-counter hearing aid available on the market. So that is a very pivotal moment in our field of audiology, now that we have an array of tools to address hearing loss. So before, we only had prescription hearing aids. It used to be called just hearing aids. Now that we have over-the-counter hearing aids, now that we actually categorize the traditional hearing aids as prescription hearing aids. So the reason why we create the over-the-counter hearing aids and overseen by FDA is that these devices will have to meet the same electroacoustic quality as the prescription hearing aids. So these are higher bar to meet than just the consumer electronic devices. On the right, you can see 3 other boxes. These are not regulated by FDA. These are just the devices that are does not have to be as good of a quality as the prescription hearing aid. So among the OTC hearing aids, there are also different subdivisions. Some of the hearing aids are based on preset. You pick one of the presets. Some of the other hearing aids are allowing the users to self-fit the device themselves. And usually the way it goes in the traditional delivery model is that a patient will need to make an appointment to go through the full diagnostic testing, and then the clinician will determine whether the patient meet the candidacy requirement for a hearing aid. And then the clinician will then professionally fit the hearing aid to a specific prescription. In the OTC delivery model, you have a hearing aid purchased from the internet or from a pharmacy, and then that hearing aid can connect to a phone, and then this fitting process is done via a connected app to the device. So that's usually the way it goes. And that's a plugin for what I do in my lab. We develop all kind of apps and all kind of interactive interfaces to allow older adults to set the hearing aid themselves based on their preference. So for example, in this middle interface here, we give them 5 different settings. They can choose among those 5 and identify the one that they like the most. And through an iterative multiple trial process, we can get the hearing aid fitted based on their preference. This is another interface as an example. So we're going through all these different designs. So what we found is that people like what they picked rather than the one that goes down the traditional prescription procedure. So those color lines are the ratings they give for the prescription that they picked versus the traditional best practice process that is in the black bar, which is on average really lower of a quality. However, there are also concerns about this kind of self-fitting procedure, though. Are older adults able to do this themselves without the supervision of another person? it turned out that this is one of the hot debated topic in our field currently. So we realized that consumers are still prefer to have access to healthcare professional or some kind of support. Well, even just help guide them through the self-fitting process. In this domain, interprofessional collaboration may make a real big impact. These older adults will just need some cheer on to be able to, do a lot more. So the reason why we want to connect with other professionals rather than just stay within audiology is because we don't have enough of audiologists in the country, and they're all concentrated in these urban centers. This is just a visualization of the distribution of audiology services as compared to pharmacies. So you see that if we can work with healthcare professionals that work with older adults, that will help reaching out to a lot more people now that we have these over-the-counter devices at our disposal. So how do we do it? So for the remaining 3 slides, I'm going to give you actual tools that you can use. So if you wonder, does my patient have hearing loss? Well, this issue has already been addressed decades ago, and the tool is very well established. This tool is called Hearing Handicap Inventory for Elderly. And there's a screening version of this, only take very small number of questions, and they take minutes, and the score going through this questionnaire, the score will tell you the level of difficulty this person struggled with. And you can see the letter E and S on the left here. You see that this questionnaire does not just concentrate on how much you hear or not hearing, but rather capture the whole quality of life issue. So it's a more rounded survey tool. If you are thinking whether to suggest maybe over-the-counter hearing aids to this patient, then the rule of thumb is that if this person score between 10 and 25, then this person should maybe consider give over-the-counter hearing aid a try. Second tool is that our over-the-counter hearing aids going to be the answer to all the hearing-related issues for older adult patients. Well, it turned out it's not. There's a number of red flags conditions that these individuals really need to seek medical attention. However, I'm not trying to have you memorize all those. There's already a tool out there. So it's a web-based tool. Then you can go in, and this only take minutes, will capture all these people that require medical attention. So these are the conditions that not just mild to moderate hearing loss tied to just aging, but there may be something more severe that need immediate attention. So last but not least, how do we know that our patients are really understand us? What people usually do is that when they don't understand, they nod and smile. So how do we know that we are making sense to our patients? So first is that let's try to be an effective speaker, meaning that we want to make our face visible to our patients. We want to consider minimize our accent because that could create troubles for some individuals, and use clear speech. What clear speech is not just loud speech and yelling, but rather speak at a slower pace, articulate clearly, and that usually wins over yelling. As a matter of fact, if you speak on the top of your lung, you distort your speech, and your speech is actually less intelligible. Last but not least, we don't want to speak with things in our mouths. So, so no chewing gum. From a technological perspective, we already have these tools in our phones. So whether you are using a Apple or Android device, You can find the live caption options in your phone, and usually when you switch it on, it will be very easy to use. So I found it very handy. So I had this on my phone at all time. So if I'm speaking with older adult patient, so I can just directly put it out, and that will turn my voice into text. So that will help them. So this is already in pretty much every single smartphone. So we probably want to take advantage of that. So these are the actual tools I'm suggesting. So if those are not enough, so our department is putting together a training program for over-the-counter technologies. And the goal is the audience, the target audience is exactly people like you, working professionals that interact with older adults. And this will be a fully remote and asynchronous program, and also present information from a manufacturer independent angle. So these are a couple of topics that we're putting together, and this program is aimed to be launched in later this year. So let me see how well I'm doing in time. This is the end of my thing. So this is the last slide. Well, if you have questions, I'm here.
Yeah, but I'll go ahead and introduce our speaker.